Imagine stepping into the operating room or, even just the endoscopy suite with a sedative that offers, well, the precision of rapid onset and an incredibly predictable organ-independent recovery.
Yeah,
For those of us navigating the complexities of anesthesia and sedation, that's not just some hopeful vision, is it? It's quickly becoming a tangible reality.
it absolutely is.
Today, we're taking a deep dive into Remimazolam, a new agent that's truly shaking up our field.
Definitely shaking things up. We've pulled together a comprehensive stack of sources for you today. Everything from detailed reviews to clinical trial data, prescribing info, the works.
Right.
Our mission in this deep dive is really to extract the most important nuggets of knowledge about Remimazolam, its unique properties, how it stacks up against the traditional agents we use, and crucially, the safety considerations you really need to be aware of.
And our goal is for you to walk away from this deep dive feeling not just informed, but genuinely ready to understand why Remimazolam is generating so much buzz and what that actually means for your patients day to day. So, to truly appreciate its innovation, let's start by understanding where it fits in the whole sedative landscape.
Good starting point.
Remimazolam is a benzodiazepine, or BZD. We're all familiar with BZDs as, foundational medications in anesthesia, highly valued for their anxiolytic and amnestic properties. They're invaluable during that perioperative period when patient anxiety can be, well, sky high.
Absolutely essential sometimes.
So at a fundamental level, how exactly do BZDs work their magic? What's the mechanism?
That's a great place to begin. The core mechanism involves BZD's binding to a specific site on gamma-aminobutyric acid type A receptors, GABA A receptors in the brain.
Okay.
This binding happens right at the interface between the alpha and gamma subunits. Now, when it binds, it causes this conformational change in the chloride ion channel.
Right.
And the crucial result is an increase in intracellular chloride concentration. This leads to membrane hyperpolarization and ultimately inhibition of the central nervous system. So it's basically about augmenting the brain's natural inhibitory pathways.
That sounds incredibly precise, yet we know that despite those benefits, the anxiolysis, the amnesia BZDs aren't always ideal as primary induction agents. What are the key limitations we often run into with them in that specific role?
That's a critical observation, yeah. While they're excellent for anxiety and memory effects, their use for induction is limited by several factors. We see variable patient responses, often reduced potency for really rapid induction, and perhaps most notably, a slower onset, coupled with those kind of lingering, long-lasting residual effects. This unpredictability makes it challenging to titrate to that precise level of immediate, profound sedation you need for induction.
And that really brings us to the agents we commonly use now, doesn't it? When we consider midazolam, what are its practical advantages and where does it often, fall short in a busy clinical setting?
Midazolam, yeah, it's a real workhorse in our field. It's fantastic because it's water-soluble, gives excellent anxiolysis, and that anterior-grade amnesia is incredibly useful for patient comfort perioperatively. Can't argue with that. However, it's not without its challenges. There's always a risk of excessive sedation, and it can accumulate, particularly with prolonged infusions or in patients who have renal impairment.
Right, the kidneys.
And its metabolism relies heavily on the cytochrome P450-3A4 system. That means significant individual variability and potential for drug interactions leading to an unpredictable onset, maybe 3 to 5 minutes, and a recovery time that can stretch out to around 2 hours. That unpredictability is a real hurdle sometimes.
That unpredictability is certainly something we constantly have to manage. Now, if we look at propofol, it's long been considered the sort of gold standard for its incredibly fast onset and recovery. But what are the trade-offs we accept when we choose propofol?
Propofol certainly earned its reputation for speed, no doubt. Onset times as fast as, 9 to 51 seconds. Recovery typically around 10 minutes. Pretty impressive.
It is.
But you're right, it has clear drawbacks. That lipid emulsion formulation carries a bacterial contamination risk if you're not absolutely meticulous. Many patients experience that pain on intravenous injection, which can be quite bothersome.
Yeah, that's stinging.
Exactly. And of course, the big one, the well-known risk of cardiorespiratory depression. It means we need to be incredibly vigilant during administration.
So we have midazolam with its, let's say, favorable safety profile but slower, unpredictable kinetics, and then propofol with its speed but higher cardiorespiratory risk and those formulation issues. What about other BZD classes? Do they offer any clues to what remimazolam is trying to achieve?
They do, yeah, by illustrating the spectrum. Diazepam, for instance, the prototype 2-keto benzodiazepine. known for its low potency and a really long half-life.
Right, Valium.
Exactly. Useful for seizures and anxiety, but typically avoided perioperatively because of that slow offset and potential for venous irritation.
Hmm.
Then you have lorazepam, a 3-hydroxybenzodiazepine. Offers rapid onset when given IV or IM, making it beneficial for acute anxiety or status epilepticus. And then there are the triolobenzodiazepines, like alprazolam Xanax. They have an added ring structure designed for a shorter half-life. But paradoxically, their higher lipophilicity and rapid absorption actually increase the risk of abuse and dependence. So you see, we've had various attempts to refine BZDs, each with its own set of trade-offs.
And this is precisely where Remimazolam truly enters the scene, it seems. It's a recent pharmaceutical innovation really designed to bridge this very gap we've been talking about. How does it promise to combine the best of both worlds, maybe propofol speed, with midazolam's favorable safety profile?
That's exactly the goal. Remimazolam was specifically engineered to address those limitations. It aims for that fast onset and the rapid, predictable recovery that we really appreciate in propofol, while trying to maintain the generally favorable cardiovascular and respiratory safety profile associated with midazolam. Currently, its indications include procedural sedation in adults for procedures lasting 30 minutes or less, and it's also approved for induction and maintenance of general anesthesia in many regions now. It's essentially a targeted solution to a long-standing clinical challenge.
So let's dive into what makes remimazolam's pharmacological profile so unique. This often gets referred to as the soft drug concept. What does that actually mean for us, and how does its refined mechanism of action contribute to its unique behavior?
The soft drug concept is absolutely fundamental to remimazolam's predictability. Basically, it means the drug is designed to be rapidly inactivated in the body right after it exerts its therapeutic effect. Predictable breakdown.
Okay, so active, then quickly inactive.
Precisely. Its mechanism still involves a high affinity for that BDZ site on GABA-A receptors, much like other benzodiazepines. Now, while it doesn't show extreme selectivity across all the GABA-A receptor subtypes, it does appear slightly more potent at the alpha-1 containing subtypes.
Ah, the sedation ones.
Right, those are thought to be primarily responsible for mediating sedation. But the net effect is still the same, augmenting inhibitory CNS activity by increasing intracellular chloride, leading to membrane hyperpolarization and inhibition of neuron action potential conduction. Standard BZD stuff there.
You mentioned the soft drug concept and that rapid inactivation. This sounds... Boil it down to one practical impact for our daily practice. What would that be, especially compared to, say, midazolam?
Ah, that's where the true marvel lies, really. Unlike midazolam, remimazolam is not metabolized by the cytochrome P450 isozymes at all, nor does it inhibit CYP450 metabolite.
It's different.
Very different. Instead, its ester moiety, that chemical group, makes it a substrate for non-specific tissue esterase enzymes, primarily carboxylesterase 1A, or CES1. This enzyme is found abundantly in the liver, yes, but also in plasma and other tissues.
So it's everywhere, basically.
Pretty much. And the practical impact for us as clinicians is profound. Its metabolism and elimination do not rely on any single specific organ system.
Wow. That's a huge distinction. So if it's broken down by these esterases rather than the CYP450 system, what's the clinical significance of that for patients with, say, hepatic or renal disease? Or even for potential drug interactions?
It's honestly a game changer for those patients. Because its metabolism by esterases is so widespread and organ independent, remimazolam's clearance is not significantly impaired in patients with hepatic and or renal disease.
Really? Even severe disease?
Well, we'll get to nuances, but largely, yes.
Yeah.
This is a significant advantage for those complex patients with organ compromise where other agents might accumulate dangerously. Furthermore, this metabolic profile means it has a very low potential for pharmacokinetic drug interactions. For example, remifentanil, another soft drug broken down by esterases, doesn't influence its hydrolysis. That's excellent for co-administration in TV regimens.
That low interaction potential is certainly a breath of fresh air. And how does this rapid, predictable metabolism translate into its pharmacodynamics? What kind of onset and offset times can we actually expect in practice?
You can expect remarkable speed and, crucially, predictability. The median time to peak sedation is approximately 3 to 3.5 minutes after an initial 5 milligram intravenous injection. Pretty quick.
Okay.
And the median time for a patient to be fully alert after the last dose, typically just 11 to 14 minutes. Some studies show recovery even faster, like 6.8 to 9.9 minutes for upper GI endoscopy.
That's fast.
It is. And what's truly impressive is its simulated context-sensitive halftime after a 4-hour infusion. It's remarkably short at around 6.6 minutes, give or take 2.4. That's a level of predictability we've really been seeking for a long time.
So we're talking about a quick journey from awake to sedated and then a quick return. Do the studies using the MOAS scale, the Modified Observer's Assessment of Alertness Sedation Scale, provide further insight into this rapid progression?
They absolutely do. MOS studies show that a Remimazolam infusion quickly moves patients from an awake state, a score of 5, pretty much directly to general anesthesia, a score of 0. What's fascinating is that it actually demonstrates greater difficulty in achieving those moderate levels of sedation, like scores 2 or 3.
Interesting. So it pushes past them quickly.
Seems so. It really underscores its rapid progression and the swiftness of its deep sedative effects. And on another note, reassuringly, a thorough QT study confirmed no significant QT prolongation. The largest mean placebo-adjusted change in QTC was just 10.7 milliseconds for a 20 milligram dose, which is good news from a cardiac electrophysiology standpoint.
That rapid transition is key for efficiency, isn't it? Particularly in outpatient settings. So where does Remimazolam truly shine in clinical practice? Let's maybe start with procedural sedation, especially for those shorter procedures, say 30 minutes or less.
Yeah, this is a prime application. Clinical trials looking at colonoscopy showed success rates over 90% with Remimazolam. That's incredibly high compared to, well, 1.7% with placebo, or even 75% with midazolam in some comparisons.
90% is impressive.
It is. And for bronchoscopy, the success rates were around 80.6% versus just 32.9% with midazolam. This really demonstrates a clear leap in efficacy for these procedures.
Those are significant improvements in success rates. Definitely. Beyond just efficacy, though, how does Remimazolam impact recovery times for patients undergoing these procedures? And how does its safety profile compare to propofol, the agent we often reach for in these scenarios?
The recovery times are highly favorable. Looking at upper gastrointestinal endoscopy, Remimazolam showed a faster time to onset, maybe 1.5 to 2.5 minutes versus 5 minutes for midazolam, and a shorter time to full alertness, just 6.8 to 9.9 minutes compared to about 11.5 minutes for midazolam.
Noticeably faster.
Definitely. And here's where it really stands out against propofol. For both colonoscopy and endoscopy, Remimazolam was found to be non-inferior in efficacy, but importantly with lower incidences of adverse events like hypotension and respiratory depression.
Ah, that's the key trade-off.
That's the potential advantage. Patients were ready for discharge remarkably quickly, too. Median times were around 44 minutes after colonoscopy and 60 minutes after bronchoscopy. This translates directly into better patient flow, maybe less PCU time, and potentially higher satisfaction.
Beyond procedural sedation, Remimazolam is also approved in some regions for both the induction and maintenance of general anesthesia. How does its efficacy and safety profile hold up in that more demanding context of GA compared to established agents like propofol?
It holds up very well, actually. Clinical trials report high efficacy rates, sometimes even 100% in certain studies, demonstrating non-inferiority to propofol for maintaining a satisfactory anesthetic effect throughout surgery.
Okay, non-inferior.
Now, some studies do show slightly longer times to loss of consciousness and extubation compared to propofol, for example. Lossy might be around 89 to 102 seconds for Remimazolam versus maybe 79 seconds for propofol, and extubation around 19 minutes versus 13 minutes. So slightly slower transitions there.
A bit slower on the edges.
A bit. But, and this is important, Remimazolam regimens often show a better hemodynamic safety profile. This means a lower incidence of hypotension and a reduced need for vasopressor support during the case.
Which is a major plus.
A major plus, especially in longer cases or sicker patients. It has even been shown to reduce postoperative nausea and vomiting compared to desflurane in some settings. And importantly, Remimazolam has demonstrated comparable efficacy and safety in high-risk surgical patients, specifically ASA Class 3, as it does in ASA Class I2 patients. That broad applicability is a major benefit for managing a diverse patient population you see every day.
Given its versatility, how do we approach dose titration for different procedures? What are the practical dosing guidelines we should keep in mind?
Right. Dose individualization is absolutely key, as always. You're always titrating to the desired clinical effect for that specific patient. For procedural sedation, especially when given with an opioid, the typical initial dose is 5 milligrams intravenously over 1 minute.
Okay, 5 over 1 minute.
Then, if needed, supplemental doses of 2.5 milligrams can be given intravenously over 15 seconds. But, and this is important, you must allow at least 2 minutes between doses to let the full effect manifest before giving more.
Gotta wait for it.
Exactly. For general anesthesia induction, common effective doses used in trials are around 6 or 12 milligrams per kilogram per hour until loss of consciousness is achieved. Then maintenance typically runs at 1 to 2 milligrams per kilogram per hour, again titrated to effect.
As with any medication, understanding the safety profile and administration essentials is absolutely paramount. Beyond individual titration, what are the specific considerations for special patient populations? Thinking about the elderly, or maybe those ASA3 patients, or those with hepatic or renal impairment.
These are critical points, absolutely. Elderly patients, so those 65 and older, and ASAPS3 patients may definitely be more sensitive to Remimazolam. For them, you should really consider lower initial doses, perhaps starting with 2.5 to 5 milligrams, and smaller supplemental doses, maybe 1.25 to 2.5 milligrams. Studies show they have higher frequencies of hypotension, respiratory depression, bradycardia, and just a generally prolonged drug effect. So start low, go slow.
Makes sense. What about severe liver disease?
Right. For patients with severe hepatic impairment, we're talking Child-Pugh scores 10 to 15 CAND-E. The clinical effects may be more pronounced and last longer. This is likely due to reduced clearance, even with esterase metabolism. So you need to dose extremely carefully, titrate very cautiously to effect, and you might need less frequent supplemental doses.
Careful titration there. And kidneys.
Here's the good news. For patients with renal impairment, including those on dialysis, end-stage renal disease, no dosage adjustment is required.
Really? None at all?
None recommended based on current data. Its pharmacokinetics don't seem to be significantly altered by renal function. That's a huge plus compared to some other agents.
That predictability for renal patients is indeed a significant advantage. Now, a crucial note regarding pediatric patients. What do we need to know about its use in younger populations? Is it approved?
This is a very important area. Currently, safety and effectiveness have not been established for pediatric patients, so those under 18 years of age.
Okay, not for kids yet.
Not yet. And we also have those concerning animal studies suggesting that anesthetic and sedation drugs in general can increase neuronal apoptosis cell death in the developing brain with prolonged exposures, typically defined as over 3 hours.
Right, the neurotoxicity concern.
Exactly. This potentially leads to long-term cognitive deficits, correlating to human ages from the 3rd trimester up to about 3 years old. Therefore, for elective procedures in this very vulnerable age group, we must carefully balance the known benefits of any anesthetic against these potential, though not fully understood in humans, risks.
Understanding the adverse reaction profile is just as important as understanding the benefits, of course. What are the most common adverse reactions we should be actively watching for with Remimazolam?
Okay, the very common ones, meaning they occur in over 10% of patients in trials, include hypotension. That's the most frequent, seen in up to 58% of ASA3 patients, so be ready for it.
58%, wow.
Yeah, it's significant in that group. Also, hypertension, including both diastolic and systolic elevations, hypoxia or respiratory depression, nausea, vomiting, and bradycardia. Those are the big ones.
Okay. Any others that are common?
Other common reactions occurring in up to 10% of patients include things like headache, dizziness, somnolence or sleepiness, chills, and just feeling cold. It's also worth noting that injection site pain seems to be significantly less common compared to propofol, which is a nice little bonus for patient comfort.
That is good to hear. This leads us directly to the critical monitoring and resuscitation protocol, which, as we know, is absolutely non-negotiable for any sedating agent, especially one this potent. Why is this level of immediate availability and specialized training so crucial with Remimazolam?
It's crucial because even with its generally favorable and predictable profile, it is a potent sedative hypnotic. So, only personnel specifically trained in procedural sedation and not involved in actually doing the procedure should administer Remimazolam. That separation is key.
Right, dedicated sedation provider.
Absolutely. These individuals must be expertly trained in detecting and managing airway obstruction, hypoventilation, and apnea. That includes maintaining a patent airway, providing supportive ventilation with bag valve mask if needed, and performing cardiovascular resuscitation.
Full ACLS preparedness.
Exactly. Continuous monitoring of vital signs, and that includes capnography for ventilation, pulse oximetry for oxygenation, and clinical assessment is essential throughout the sedation and the entire recovery period. And crucially, resuscitated drugs like vasopressors, plus age and size appropriate equipment for airway management and ventilation must be immediately available, right there in the room.
And the reversal agent.
Yes. Because it's a benzodiazepine, the reversal agent, flumazenil, must also be immediately available for use. It effectively reverses the sedative effects, although you still need to monitor patients carefully for resedation as the flumazenil wears off.
That comprehensive preparedness is paramount, absolutely. In terms of drug interactions, what should we be especially vigilant about when using Remimazolam? Any major ones to highlight?
The big one is concomitant use with other CNS depressants. You must be extremely vigilant here. Using remimazolam at the same time as opioid analgesics, other benzodiazepines, propofol, or even alcohol can significantly accentuate the sedative effects.
Synergistic effect.
Hugely synergistic. This can lead to profound sedation, severe respiratory depression, coma, and even death. It's critical. Patients should be explicitly advised to avoid alcohol for at least 24 hours prior to administration. No exceptions.
Got it. Are there any specific contraindications or other important warnings we need to be aware of before considering Remimazole?
Yes, there's one key contraindication you absolutely must know. Remimazolam is contraindicated in patients with a history of a severe hypersensitivity reaction to dextran-40.
Dextran-40, why is that in there?
It's used as an excipient, a bulking agent in the formulation. So if they have a known severe allergy to dextran-40, remimazolam is out. Hypersensitivity reactions, including anaphylaxis, can occur.
Good to know. Any other warnings?
Other important warnings include the potential for anterograde amnesia. Similar to midazolam, patients might not remember the procedure. And while its use is typically acute, it's worth noting that, like other benzodiazepines, long-term use would carry a risk of abuse and dependence. Also, watch out for paradoxical reactions, things like agitation or involuntary movements. These can occur, seem to be more common in elderly patients or with particularly high or rapid doses.
Finally, let's talk practicalities. How is Remimazolam actually prepared for administration, and what are its compatibility guidelines? Are there any common pitfalls we should try to avoid when reconstituting or mixing it?
Right, the nuts and bolts. Remimazolam is supplied as a lyophilized powder, usually in 20 milligram or 50 milligram vials. For the 20 milligram vial, you reconstitute it with 8.2 milligram of sterile 0.9% sodium chloride normal saline. That gives you a 2.5 milligml solution.
Okay, 8.2 millimole for 20 milligrams.
Exactly. For the 50 milligram vial, you reconstitute with 10 milligram of 0.9% sodium chloride. This gives you a 5 milligml concentrate, which you then need to dilute further, usually down to 1 or 2 milligml, for administration depending on your intended use, like infusion versus bolus.
And how do you mix it?
A crucial tip. Always gently swirl the vial to dissolve the powder. Do not shake it, as that can cause foaming and make accurate dosing difficult.
Gentle swirl, no shaking. Got it. Compatibility.
It's compatible with several common IV fluids.
Yeah.
0.9% sodium chloride, 5% dextrose, 20% dextrose, D5 half normal saline, 5% dextrose, and 0.45% sodium chloride, and Ringer's solution.
Okay, standard stuff mostly. What about incompatibilities?
Yes, this is important. It is incompatible with lactated Ringer's solution, LR, acetated Ringer's solution, bicarbonated Ringer's solution, and other alkaline solutions. This seems to be due to its low solubility at pH 4 or higher. So no LR.
No LR. That's a key takeaway.
Absolutely. And the general rule of thumb is do not mix it directly with other drugs or these incompatible fluids prior to administration. Flush the line if needed.
So after this deep dive, wrapping things up, what does this all mean for you as a medical professional? We've unpacked Remimazolam, and it really does stand out as a next-generation benzodiazepine, doesn't it? For both procedural sedation and general anesthesia.
It really does.
Its soft drug nature, allowing for that rapid organ-independent metabolism by esterases, means highly predictable onset and offset. That makes it a powerful and potentially a remarkably reliable tool in your armamentarium.
Precisely. For medical professionals like you, this unprecedented predictability, combined with what appears to be a favorable safety profile compared to some existing agents, it directly translates to potentially better patient care, maybe fewer surprises in the OR or the procedural suite, and just greater control in the perioperative setting. This is especially true for those complex patients, the ones with significant comorbidities like hepatic or renal impairment, who often present real challenges with our traditional sedatives. It's really a testament to how targeted pharmaceutical innovation can directly and significantly improve patient outcomes.
It's truly fascinating to see how far we've come in refining sedation. As we integrate this incredibly promising agent into our daily practices, it makes you wonder, doesn't it? What further niche applications might its unique properties unlock in complex patient populations beyond what we've already explored today?
That's a great question.
And how will its rise continue to refine our approach to truly individualized and perhaps incredibly efficient anesthesia care in the future? Definitely something to consider as you continue to navigate the exciting advancements in our field.